Okay, so very pleased to have all of you here today for Talking Public Health, and we are very pleased to have our speaker, Opeyemi Babajide. Who's a postdoctoral research fellow at the Urban Health Collaborative at Drexel University School of Public Health. She earned her doctoral degree from the Faculty of Public Health, Department of Epi and Biostats at the University of Abadan, with a focus in medical demography. Her research focuses on population dynamics, health disparities, and mortality. She was previously a research fellow at the 3D Commission at the Boston University School of Public Health, where she contributed to pioneering research on global population health at the intersection of social determinants and data science to inform decision-making. I don't suppose you guys need, did you? Possibly. At the Urban Health Collaborative, her work takes a dual approach. She explores the complexity of urban health and ways to strengthen non-healthcare systems for sustainable cities. And locally, she focuses on improving maternal health outcomes among Black immigrant women. She also co-leads the Black Immigrant Health Working Group. That's her commitment to community-led research in Greater Philadelphia and beyond. So really excited to hear your work today, and I'm going to turn it over to you. This is a great crowd, so you're going to have fun.
Thank you very much for having me, and thank you everyone for coming. This is a good turnout. I don't know what I was expecting, but yeah. You've all made my sleepless night of preparing the slides worth it, that a lot of people want to listen to me. I was watching Dingalia's assembly, and it was talking about the fact that it was terrified being in the chapel, and it was quite nervous because it was raised Catholic. I was raised Pentecostal, so we like a little bit of feedback. So good afternoon, everyone. Thank you. Fantastic. So I want to thank a very close friend of mine, Dr. Lagoke, is here to support me. All right. She's my friend from college. And in fact, she was the first person to talk to me about WashU for years. She just kept going on and on and on about WashU. And I just felt like, okay, I don't know. I mean, it's not even on my radar. I don't even know what you're talking about. And all of a sudden, I talked back to her about WashU, and she said, I have been talking to you about WashU, and I feel like it's fast becoming a pilgrimage destination for public health professionals, the amazing work that you're doing here. So I think I've come full circle. If anybody asks me what I've done in my life as a public health academic, I came to WashU school. All right. So today, while I work a lot in urban health, and in the last 5 years, actively thinking about cities and how to make health better, I have decided today to talk about something that is quite dear to my heart, and I'm thinking about more closely locally, especially as we navigate how cities, and right here, I'll be talking about Philadelphia, but this could actually be generalizable at some point for every city in the United States. I do know that the North Coast can be very different, but I have seen some similarities since I came here last night. Okay, so allow me to feel free and feel home, like I'm discussing with some of my colleagues in Philadelphia. While I know that the context might be different, I do think that this is an important topic to talk about. All right, so in no particular order, I'll be talking about migration, perinatal health, and social determinants of health. For the purpose of this presentation, I pretty much just set some standard of how I'm thinking about perinatal health according to the definition of the WHO, and talk about social determinants of health, which, by the way, I'm not trying to talk a lot about. I think Galia would do that a lot. I mean, I can't out-talk him on social determinants of health, but I would focus a little bit more on where women and their children live. And I'll talk about migration. Those stories, I will talk about them with some of my past research, and I'll talk to you about some of my current thinkings, how I'm thinking about things, how I'm framing some of those researches in my mind, some of my submissions to the wonderful NIH, some on the review, and some ways I feel like we can advance research in this area, even for several people. It's multidisciplinary in nature. If you're working, Laura, for instance, working in food insecurity, you would find your peak right here. Housing, you will find your peak right here. Just to mention a few things. And then I will try and do a bit of summary, and then we'll go into Q&A. So the broader discussion that I'll talk about is how does migration impact some of the known relationships between perinatal health and social determinant of health. I am not trying to say that I mean, researchers have spoken a lot about perinatal health and social determinant of health. Those are known factors. I do think that what we do not know is how migration actually, affect that relationship or impact that relationship. And then we'll talk a little bit about that. Like I said, perinatal health encompasses about the health of the woman and our child before, during, and after pregnancy. And according to the WHO, it talks about the fact that talking about once you have 22 weeks of complete gestation till about 7 complete days after birth. I think sometimes a lot of researchers have been very flexible about that, talking about the fact that some women might register for antenatal care well before 22 weeks and everything, but this was what the WHO definition given. And then for social determinants of health, the condition in where we work, where we live, where we play, worship, where we age, and how it affects a range of health outcomes. And for the purpose of this conversation, I'll be focusing a little bit on where we live, and we'll be talking about where women live. And I like this figure a lot. I don't know, maybe because people are walking, maybe it depicts migration a little bit. But according to the UN migration, it's the movement of people from one place to another. And usually if people have stayed for more than 12 months in a place, it might be within a state, but for this purpose, we're talking about internationally. So you'll be hearing me talk a little bit more about foreign-born and US-born migrants and everything and all that. So where women and mothers and their children live, and this is where I get a little bit into my story. So early enough in my graduate career, I started seeing studies highlighting the fact that I'm under 5 mortality, maternal mortality, and high burden of diseases in Africa. And this particular screenshot is from the burden of the global burden of disease, and you can see the very dense part where we have the most saturated colors. It's some part of Africa. I am from somewhere. Where's my pointer? I'm from somewhere here. Oh, my pointer is lost in the. Anyway, this is Nigeria. I feel like even the map is very beautiful. So I'm from somewhere there, and so we have this high burden of diseases, and very early in my career, this also informed how I was thinking about things, because my first study was on under 5 mortality, and similar to what we have for the burden of disease, which might not be surprising, we also have high burden of maternal under 5 mortality in sub-Saharan Africa. Looking at that again for Nigeria, very high. We fell into the category of more than 100. 100 that's by 100, thereabout. So quite very high. And then the last one that I'd like to show you is the one for maternal mortality. This one is quite colorful, and Nigeria also fell around the red, extremely high, about 1,000 maternal deaths by 100 live births, as high as I could be. And again, we don't have complete vital registration system, but so some of those things are estimates gotten from data like the DHS data and some maybe hospital-based data sets and everything. So now I'll go a little bit into the meat of what I have done in this regards, just how some of those things actually frame my thoughts. And my first study, like I was talking about, is looking at the disparities in the patterns and the predictors of under 5 mortality in Nigeria. So this was trying to look at how we can see some of the determinant factors of child survival for kids that are under 5 in Nigeria. And like I said, we have a depth of data, and there was no complete vital registration system. So I used the much appreciated NDHS data, the Demographic and Health Survey, which I'm beginning to hear is going to get back online very soon, hopefully. And so for the purpose of this talk, I would like to talk about some of the things that we found. And so I didn't go deep dive into the design. I use a cross-proportion as a model, which I love to talk about. I could talk about all day. And so if you're so inclined and you're a data person and you like other methods, I put the QR code there for you to read, and then you can get in touch with me, and then we can have all this nice talk about data and methods. But I just wanted to talk about this. And so for this cross-proportional, cross-sectional data, population-based, we took a cross-section of women that answered questions about their children, and it was much about the fact that very basic, about 28,647 women asking them questions about the fact that, is your child alive? Yes, no. And so the demographic health survey collected data for up to 10 children, saying that if child A is alive or child A is not alive. So the woman answers yes, no. And for every child that is alive, we say, okay, how old are they, the current age? And for every child that is dead, we'll say, what is the age at death? And so that we're able to use that to perform some survivor analysis, get the predictors and some of the, just look at what are the assets of a child living up to a certain age, and what are the ages and everything. But for the purpose of this talk, some of the key findings that we found are some of the very popular culprits, like education levels, household size, like people that have more than 5 children, the kids have more, they are higher at risk of not surviving up to the age of 5, and people that actually have low enrollment in antenatal and postnatal care, obviously. And we found that even though we're not able to disaggregate the data to know where this was coming from, we found that generally the practice of early motherhood with high fertility was actually also very particularly strong in the analysis and the region of the residence. So I think that one of the things that, and I was talking to some of the students today, one of the things that this kind of research did for me was that even though it earned me my master's, it got me a little bit more confused and curious to say that I am from the southern part of Nigeria, and if educational levels actually came in the South, people are very much educated. For instance, in the South, people potentially have high level of antenatal and postnatal enrollment, and in the South, actually, we don't have a lot of cases of early motherhood. So people don't give birth on time, and people give birth between, I think the average priority in the South at the time was about 4. And in the North, we do know that we're having up to 7 and 9 and everything, but we didn't have enough data at the time. And I think I just didn't understand at the time what next I could do, to actually deep dive into the data and begin to uncover some of those intricate things to be able to see what I can find as to how, what was causing some of these things, even though we were at this point able to actually find some of the predictors, and we saw a particular pattern in the story. And given by literature, we do know that, okay, this is not the same for every state in Nigeria, for instance, but we're not able to uncover that at the time. And that led me to the next thing when I had the opportunity to actually go for a doctorate level. At this point, I was looking at maternal mortality, because I then found that, okay, we're talking about the children, then if we're also looking at the health of the mothers, we would be able to do better. If we do better for the mothers, be able to bring policies and programs for the mothers, then maybe we might be able to also have some better outcomes for under 5 mortality. For instance, if women have more education, the educational levels of women, because all the factors that you can think about, that most of them were actually related to the mothers. It wasn't about obviously about the children, except for something like even the region of residence. A child does not determine where to stay and everything. And so I said, okay, why don't we look at maternal mortality using the same data set, but pulling it together for over 10 years between 2008 and 2018. So I adapted, at this point, I was a little bit more knowledgeable, and then I adapted a small area estimation again I do know that someone was interested in small area estimation. I can chat over this if you go through the QR code and everything. So I use a empirical Bayesian method. And what I did was, in the absence of complete vital registration system, once again, then I then took a deep dive to say that we have 36 states in Nigeria with the FCT, that's 37 regions. And we have 6 geopolitical regions, which is similar to something like, I don't know if it's exactly similar to what you have in the US right now. But what I can say is, when you have geopolitical zones, meaning that they're probably not the same ethnicity, they don't speak the same language, but geopolitically they were already partitioned in such a way that if a president want to come out from this geo zone, we all know, oh, this is the Northwest, this is the South, this is the Southwest, etc. And so it was at a time where we had 545 maternal deaths per 100,000 live births recorded by the NDHS data. And it was causing a lot of rancor in Nigeria, saying that we don't have it that high. We have it that high. It can't be that high. We have had a lot of programs for maternal and child health. So there were a lot of argument on how plausible these estimates were, and people were beginning to advocate to say that I think we should start collecting our own data, because now we are not so certain if these estimates are actually working for us. For instance, we have all these programs going on in cities like Lagos and Ibadan, and having all those motherhood programs so people expected that, oh, I think we are doing better from what we had done before 2008. We should actually have something better. So if it's not moving from the 595 that we had previously from the released estimates, and it's just moving a little bit to 545, then we should start questioning some of those things. So I and my mentor said, okay, why don't we look for a way to see if we can use the same data sets to say, how do we disaggregate this for the states and for the FCT? So that was why we used the small area estimation. So this particular one was a cross-section of women. So if you understand a little bit of background in demography, it's called the sibling survival method. So what this potentially just really means in simple terms is that all the women respondents were asked about the children that their mothers had. So for instance, respondent A will be asked to say that how many female children were birthed to your mother, and she will say like 10. Well, let's say 3, 4, 5. I know that 10 sounds high, but yeah, we potentially have some that had 10. And then, so they would say, ask questions, further questions. I think it was 4 major questions. They will ask further questions to say that, is sister A alive? Yes, no. And then the next question will be that if sister A is not alive, is the cause of death for sister A, was it pregnancy related? So we could not measure maternal deaths in the DHS data, but it was pregnancy related, but it was good for us. I mean, it was better than nothing, in a sense. So when I say yes, no, and all that, then they will ask one more question to say that what was the age or something like that, sister A person, and there was space enough for 10 sisters. So this had the limitation of recall bias, but it was the next best thing that we could get in the absence of complete vital registration system. And what we found, remember when I was talking about this, we only had an overview of having the educational levels, the household size. We knew the things that were causing the under 5 mortality that we were experiencing, but we couldn't deep dive to say that the practice of early motherhood is a little bit cultural for Northerners more than the Southerners, but we don't have data for it. And we all are advocating for evidence-based policies, right? So we couldn't make any assertions whatsoever. And this is this very figure that took me nights in ArcGIS at the time to create during my doctoral program. In fact, I was so proud of this particular figure that when I was printing out my dissertation, I spent a lot of money printing this figure. So, I mean, it's the things that are important to you because it was so beautiful. I'm like, yeah, I mean, we can see that beyond just the figures and everything. So I'm looking at the legend, and again, this is where I am from. Oh, I'd like to show you where I'm from. I'm from here. I'm the Falago here. I'm high schooled in Oyo State. So we are on the borderline about 300 to 500. So similar to what I had thought I guessed what was going on during my master's program, you can see it here. There were a lot of states in the northern area that were actually contributing to the burden of maternal mortality. And carefully, I couldn't make the assertions to say that. I think that was what we're trying to say, that not all the states in Nigeria, 36 states and the FCT, 37 subpopulation were contributing to the high under 5 mortality, all right? So we found out that, okay, people in the Southwest, where I said that we have some measure of better education going on, had, like, it wasn't relatively to high income countries, it's still very much high, to 100 to 300, but we're just looking at where the burdens were really, okay? So as I eventually guessed during master's that, okay, where we have all the early childhoods going on, potentially female genital mutilations and everything going on, the large household size, close birth intervals, early marriages, so early marriage, close birth interval, high fertility. I mean, those are very closely co-occurring things that could potentially affect the health of women. And then this was what we found out in that. And after this, I mean, and then I had the opportunity to actually work with the 3D Commission, where we're looking at the social determinants of health generally, globally. And even though this is an analysis that we published as a commentary, we found that similar to what I found in Nigeria, this is the cluster map of, so this actually, this is in Netherlands, and what they did in this particular, the program is called Rotterdam for Mothers. And what they did was the ONG and the pediatrician doctor that we actually now worked with, we're finding out that mothers bring children from a certain area in the Netherlands, and they found out that their health outcomes were a little bit not faring as well as other people in some certain areas. So they did like a score, like a social work score with the program, and they were able to score the mothers, and they found out that they were clustering around a certain areas in the city. So it wasn't everybody. Again, you see, this was framing my thoughts to say that I've seen this before. When you have a certain general knowledge of things are good, but it's not so good in the area, or things are bad, and it's not so bad in my area, you know, in that sense. I said, I've seen this before, in that sense. And again, another study that I collaborated with some of my friends from the UK, and we found out that even this was in Lagos, the city of Lagos. So this particular study, what it was looking at is to look for how long a woman traveled from her house to emergency obstetric care. So what we did, and I was actively part of the data collection, was that we go into the hospital records and we look at the address that the women provide to say that this is where I am coming from. I traveled here, and then we put that into Google Map, and then the address of the hospital into Google Map, and look at the travel distance. And we found out that women that were clustered in certain areas, especially the water right area, outskirts of town and everything, where potentially, as Ben said, have better, primary health care and emergency care and everything, actually traveling a lot. You know, and then it's a long distance. So the places where a woman lives right here, the places where she lives in Netherlands, in an high-income country, the places where she lives in Nigeria, and the places, the places where she lives in Nigeria, the places where a woman lives right here in sub-Saharan Africa, started shaping that, okay, generally thinking about the fact that we are thinking about social determinants of health, I would like to actually look at what is this thing about where the women and their children actually live that is actually affecting their health as much as it is affecting their health. And so this is my current reality. Personally, I migrated into the US fully 3 years ago. So this coincides with some of my thoughts and on how I am thinking about some of the work that I've done in the past and some of the things I'm currently thinking. And this is where I would like all your questions and your feedback. Why am I thinking about migration? Okay, so I think it was about 2 years, 18 months exactly. A senior colleague of mine had shared the report with me from the UNFP, and I will show you the report. And again, it was one of those things I just said, I have seen this before. So this is always a case of how my research always starts. It's just, I have seen this before. And then I get into the literature for days, and when you ask me what am I doing for fun, I'm reading for fun or writing grants for fun or whatever the case is for. And so when I got that, I'll get to that particular write-up, but I wanted to show you this. This is a screenshot from the Pew Research Center. So about one person out of 10 in the US that is categorized as a Black person is actually an immigrant right now. I know some of those things are known, but some people don't really know them, but it's the truth. Like, so we have a huge, in the Philadelphia area and most of the East Coast states, we have a huge Black population. But right in that population, 1 out of 10 people are immigrants. And at the list, there is no way to trace that, because even when we are filling the forms, we are all like, what race do you belong to? Black. And my son and I have this argument every time. He tells me, "Oh, Mom, we are African American." I'm like, "Yes, we are, but I think I'm Nigerian." Well, it's like, okay, feel that in the form. I'm like, okay, you are right in that regards. Okay, but yeah. So I just think that this is very interesting because if you can look at this graph very well for folks that are really into data and it gets them excited. And so I have this too. I have this for folks that are not so like in the graphs and everything. So between 2010 and 2019, I think this potentially will like really increase more than we can see from 2010. Was gradually moving, and it's now projected to up to like 9.5 million people by 2060. This might not be like a big deal right now, might look very interesting, but something is quite interesting to me there. So approximately in the last since 2019, we have had 2.1 million sub-Saharan African resided in the United States, and it has increased in the past 4 decades. Okay, so just note, 3 times more likely. And for the context of this talk, I will be talking about the Black immigrant women. So women from sub-Saharan Africa and Caribbean, but I just potentially wanted to look into the magnitude of the experience. I think I get started. So this also, and as just like at FYI, this also coincides with the time where we have the new visa policies in the US, where you have visa diversification, the visa lottery, the DV lottery and everything. So while the Caribbeans are continually increasing since 2020, the sub-Saharan African immigrants have shot up to 136%. 137% since 2020. These are some of the backgrounds that I just wanted to put in your mind. So why is this very, very important? This is the study. I just think this potentially just changed my life, my research life in a very nice way to start thinking about America, because if not, I'll just be thinking about the global cities and everything. I just think that after I read this, and it said that in the last 2 decades, that's the same time where this population began to shoot up. Yeah. So it says that in the last 2 decades, maternal death had doubled in the US, and Black women are 3 times more likely to die in pregnancy or childbirth than white women. I just felt like I said before, it chases me everywhere. A population has a particular estimate, and somehow I read about it and I'm like, no, it's something is not right. I've seen this before. It can't be that we have this huge thing and then you say, okay, 3, something must be driving this thing that we are not looking at. Something always just tells me, look into it a little bit, look at it a little bit more and everything. So when I saw that in the last 2 decades, when I was studying about the migration and found out that we are having a lot of Black immigrants coming to the US, it's also coincided with where we have maternal deaths that have doubled in the US. And potentially, they now said that furthermore, Black women have 3 times more likely to die in pregnancy or childbirth than white women. Then, of course, you will find me there, anything that has to do with something like this. So I put the graph. Also, this is from this report from UNFPA. I put the graph there to see how we have done in the US. So that is 500, So that's like 55.3 and against 18.8. Maternal deaths per 100,000 live births, which is quite small to what we saw in Nigeria, but potentially still high because the US had better statistics than this previously. All right, so when I saw that it was also 3 times more likely, then I began to think about it a little bit. And next, I'll go into some of the gaps that I noticed when I began to read this and I began to read literature. So even though we have this potentially Black women 3 times more likely to die in pregnancy than white women, I obviously said that, okay, from my perspective of always trying to disaggregate data, there is something deeper going in here. And from my conversation, like I told you with my son, who calls me an African American, and I told him that I'm Nigerian, I do see that, okay, so at some point, everybody has been lumped into a monolithic group, and then we need to start looking at a little bit into this. And then my disaggregated brain came up to let's disaggregate this a little bit further. So we found out that there's heterogeneity in maternal outcomes for Black women, which means that immigrant women may face more adverse outcomes other than Black women. And I would just, because I know that most of them I know, I would just like give a background a little bit. So I feel like because of the systemic issues that are going on, acculturative stress that might go on when women actually migrate from one place to another, the loss of their social support and all that, it made me start to think that, and my lived experience to think that if you move from one place to another and leave all your known to an unknown place, if the particular population that you are moving, the enclave, let's call it an enclave right now, that you're moving into is potentially going through a challenge, because you are going through some of those stresses, then you might be a little bit doubled disadvantaged in that sense. Then found out that even though the pregnancy-related death primarily were linked to causes like cardiovascular diseases, cardiomyopathy, and they are more prevalent for Black women, that the Black women actually now experience that 5 times more than white women. And my favorite of all time, I then started looking for data to say that how do I disaggregate this for Black immigrant women? And there was a dearth of data to disaggregate this further from just the Black race to looking at where the women were actually born. The next one is that the protective social determinants of health that exist, that we know by literature, education, income, access to care, housing, housing, food security, everything. In that sense, to mention a few, even though that those protection exists, but the evidence was suggesting that they were insufficient to actually overcome the gaps for maternal health outcomes experienced by Black women, because for a Black woman that have higher education and college education and higher, they were 5 times more likely to actually experience adverse maternal health outcome compared to the white women. So that shocked me to the bones, because we are big on social determinants of health, where we live, where we play and everything. And if we can actually get people to be, like, I'll call it a spectrum, to be on that spectrum, like improve their experiences of social determinants of health, then we could potentially have a lot of literature to support the fact that then the health outcomes will be better. But when I looked at that particular fact, and it says that it wasn't better for Black women, then that was another gap I saw, and then led me to how I'm thinking about my current research. So my current research, I'm thinking about that in line of the life course perspective. And this is thinking about that, looking at the vulnerable windows during the life course. So you can see the childhood, which I've dealt with a little bit, the perinatal period, pregnancy, right? This is like very known for an established fact to say that those are actually very vulnerable period. And I put this picture there just for emphasis. And thinking about this in terms of migration and my current research, I think like thinking about the early life and the pre-migration status of women, and thinking about the social economic conditions that women are in. For instance, we do know, like right now, I think the literature says that an average of, and I think I was checking yesterday, about 18% of people in sub-Saharan Africa live below $1 per day. So looking at some of the social economic conditions, looking at the high maternal mortality burden that I've shown you with the global data and with the work that I did in Nigeria, looking at the limited access to quality healthcare for the kind of women that have to drive through emergency obstetric care, and maybe the 3 delays is just violated in that sense. And looking at some of the things that I've spoken about gender norms, like female genital mutilation, and some of the early life experience, like infectious diseases, nutrition, all the like very known stuff that we have known in literature. I feel like the life course perspective helps me to like tie my thoughts together on how I'm thinking about this for the women. So we call that the pre-migration factors. And the next one is the migration pathways. So I was talking about in the last 20 years thereabout, I think it was in 1981, where we have the new policy on migration and having a diversity program. So people come in, and then more recently, we have a lot of internal settlement issues, even in Africa, in Asia, and I mean, all across the world, and people are coming into the US as refugees. So there are pathways to which people come into the US. You have refugees, you have students, you have family-based visas, and you have work visa. And even looking at this already, we know that once people come into the US, they would interact with the social determinants of health very differently. There was going to be a huge gap on how I mean, for instance, I think I was talking when we're talking our conversation with a student, I was talking about the fact that some people have stayed in settlements within their own country when they were unsettled, and then have like internal refugees, small internal refugee settlement before they actually even move to the US, right? And so after they move into the US, most people are not moving to the US like some of us did. Like I got a job, I got a student visa, I got stipends, nothing, zero, like starting from the scratch. So on that front of income and all that, they're like on zero level. They might have education that might help them after they get papers to stay, but like their stress is already transported with them through migration into the US, okay? And then you have people that are family-based that might have social supports. So they would experience that aspect of social determinants of health a little bit differently. You have work and you have students, okay? And the last one is actually to look at once they've now migrated into the US, we have the acculturative stress. And we have the social isolation that's possible, the economic instability for even people that come to work, like you're starting your savings. Some people come in, use their savings to move. Some people try to travel, use their savings to move. And then you look at the systemic issues and inequities that already exist for the Black community that is lumped together and treated as monolithic. And then we look at the healthcare accessibility and cultural competence, which I'm actually in recent times, in the last 2-3 weeks, I just taught a course on public ethics to doctoral students. And we are beginning to say, I don't think it's cultural competence, it's cultural humility to be able to actually learn the culture of other people. But for the purpose of the agri-lingua, I didn't want to like bring in my new thoughts into this. So that's some of the things that I felt like I wanted to look at in my study. And in this study that is under review with the NIH, and this is one of the works that I do for my Black immigrant work group. It was funded by, we have a small pilot fund and then the Cotworth Fellowship for like a year. And so the main hypothesis I'm just looking at here is that I want to just establish, first of all, that migration plays a pivotal role in influencing how social determinants of health actually affect maternal outcomes among Black immigrant women. And thinking about some of the things that I talked about here, their pathways and how they actually acculturate and come into the system. That is a huge deal. But I do know that even though that is obvious and I do not have a lot of data to work with, I know that there are causal pathways that if we know them, then we might be able to make better decisions and form tailor-made. And I feel that word has been used a lot, but like tailor-made interventions and programs for Black immigrants so that we don't lump the programs together to say that, oh, this is a program for Black mothers because they are experiencing this, but something that they will be able to relate with and all that. So this is a framework that I am looking at that I derive like potential pathways. So look at the social determinants of health. Okay, I'm conscious of time. Look at the social determinants of health right there. And I'm saying that for the, let me see. For this particular aim1 to describe the disparity of SDOH, I'm looking at that with the dotted line, just to say that social determinant of health, so the social determinant of health measures in this particular data set that I will talk about right now affects maternal health. And the second one, I am saying that we need to investigate that the migration in itself moderates the relationship between the social determinant of health and maternal health. And the last one is that I'm trying to now see the causal pathways, which is a solid lines, okay, all those nice webs in there, looking at the migration pathways, the pre-migration factors, the post-migration experiences, looking at how social determinant of health is affected by cultural factors from the women's pre-migration life, social support networks, the policy environment itself fits into social determinants of health. And then, they have put there as maternal health. So while trying to look at this, like I told you, I look at a few national data sets and I couldn't find, and I'm looking at using the Philadelphia pregnancy PRAMS. I know a few people know the PRAMS data sets, but most of the PRAMS data sets do not allow for disaggregation, not even most, almost all, do not allow for disaggregation of data. But the city of Philadelphia, where I live and I'm very proud of, maybe for a while, collected some data and linked it up to the birth certificates, and they were able to get the country of birth of the women. So we're able to actually use that to get some preliminary data and disaggregate by foreign-born women, and foreign-born Black women and US-born Black women. And these are some of the questions that, generally trying to think of how to do this as a mixed method and see how the disparity in social determinants of health influences maternal health for the Black immigrant women and how migration moderates that using the Philadelphia PRAMS, for the quantitative piece, to some regression analysis and some descriptive statistics. And for the qualitative piece, which is quite the meat of the study, is to look at the causal pathways and the mechanism by which migration affects it. Look at the lived experiences of the women when they were coming into their. Let's see if you can collect some of the focus group discussions and the IDI. Look at how their pre-migrative life, how that affects how they even migrated into the US and how that is currently affecting how they are living in the US and how they are experiencing some of the social determinants of health. And then we'll do some triangulations to see what are the insights that this can provide for developing effective policy intervention. I put here, just for the sake of people that might not be very familiar with the PRAMS data sets, these are some of the measures that I'm using because it doesn't collect data directly about social determinants of health. So I'll be using some principal component analysis to pull some of the variables together and then get scores for the 5 domain, which is education, economic stability, like asking a question about their food insecurity, housing insecurity, the healthcare access, the neighborhood and built environment, and social and community context. And I would like to share with you some of my preliminary results, which I found to be very interesting. And so in here, it's a weighted analysis. So these are weighted proportions. So in here, we can see that already the Black immigrant women actually had high proportion of Black immigrant women, foreign-born women, actually had diabetes before pregnancy. And I would just list those things with a red. They had no insurance before pregnancy. They had no insurance during pregnancy. They had no insurance during postpartum. And this was quite news. I met with an NIH program officer and she said, oh, the US, everybody has insurance during pregnancy. And thankfully it was Zoom, right? So I could react under my table like, right? Yeah. So they had no insurance. They had stillbirth. Babies are still in the hospital for whatever reason. We have not been able to deep dive into that. Most of them lost. Well, they had a high proportion of people that lost their jobs during pregnancy. Thankfully, they were not so homeless. Gestational diabetes, food insecurity, and they did not have enough to eat in the last 30 days. Those are like very huge things that I was looking, like pointers to the social determinants of health that I would like to study. And yeah, so that leads me to a few of the things that I am now thinking of on how this might potentially affect some of the policies. I think that some of the local implication of this and how I want to progress this into global and local public health is that we can be able to have tailored community-based interventions for immigrant mothers. We can have data-driven and culturally appropriate health policies. And we can have some cultural competent health system that understands what the experiences of the women are. And then maybe we can reduce some of the preventable deaths. We can also enhance some of the social support structures. And for this, I'm not only talking about the structures that come from people, but also the social determinants of health structures and how people actually interpret those and experience those personally. Maybe for instance, and this is just hypothetical, maybe WIC is not the answer for a Black immigrant woman, for instance, but it's like a huge program that is getting funded, but it might not be the specific things that the Black immigrant women need. Maybe what she would need is a community that would have gardens together and they can build, and they can plant the foods that they can actually understand and eat together and all of those things. Some of my hypotheses. And so some of the global implication of this is that because sub-Saharan Africa that I am from and a lot of Caribbean, people are migrating to other high-income countries regardless. So I'm feeling that this will be comparative insights for other migrants in other countries. We can influence some of the global health policies and maybe start advocating for disaggregated data, not only in the US. If it becomes a major thing that we start doing by country of birth of the women, for big surveys that every country collects, then that becomes a norm. So it's not like something that we're trying to do extra and the funding goes into that. And of course, hugely will reduce global maternal burden and then maybe improve some multi-sectoral collaboration and see how several multilateral organizations that actually deal with women, deal with migration can actually come together and start improving health for migrants. Yeah, and in summary, I say health is cumulative and it shifts over time, perinatal health. Social determinants of health impact health trajectories, and the effects can differ from one location to another. How a woman, it might be social economic status in a particular place, and when she goes into a place is how she interacts with the healthcare system. Then migration is a key transition. I can say that for a fact from lead experience. There is an ongoing demographic transition among Black population. So they are no longer like a monolithic group. It's like a huge number of migrants are in that group right now. And we can actually advocate for disaggregation of data so that we can have some informed prioritizing of research agendas. And thank you. Well, I made it. Thank you very much for listening. Questions? Thank you.
First of all, thank you. In many ways, I think the best research is informed by people's own lived experience, which clearly yours is, and so it's great work. It's really interesting. I'm sort of interested in two things, one that's probably easier and one that's harder. One I was thinking about, like you called the pathways, more forced migration, which is millions and millions of people right now, and then more voluntary through education or work or other things where it's under the purview of someone's control a lot more. And are you dissecting those a little bit more, and what would it take to learn? Because I can imagine like the future interventions could look very different by those groups.
Thank you very much for asking that. So let me talk about the fact. So I will be talking a little bit more informed because right now I'm in discussions with a lot of community-based organizations that actually work with refugee groups. And I don't know if everybody knows, this might not be a thing in San Luis. So last year and 2 years ago, from December to last year, just before November, we were having buses drive into Philadelphia with migrants, Black migrants, daily. And the community-based organization that I partner with would wake up and come to their offices and they will have 30 migrants at their door, mostly. Now I have gotten this new terminology from you, voluntary and involuntary, that were involuntary migrants, like they didn't want to migrate, but because of the situations, they found themselves and they're refugees. So we do now begin to see, because even among the Black migrants that we are working with, we do see that there is a disconnect between people that are refugees and people that are coming through family-based work or students. In fact, I do think that some refugees feel like they are a little bit more disadvantaged because I don't know how to put it this very well, but let me put it this way. So I think that one of the things that I'm trying to look at with the focus group discussions and the interviews is to ensure that we get the uniqueness of everybody's pathway into the US. So it's not, while it looks like it might be difficult, it's not so impossible to actually be able to do that because the community-based organizations already have those people coming to them. I remember that I was in the city, in the mayor's office for the African Caribbean meeting. They usually will have like a town hall meeting, and 300 Black immigrant guys worked in just to solicit to say that we are here. They said it's not true. We are sleeping in mosque. We are sleeping in people's houses. Like, can we get stuff to do? Can we get our papers moving? The legal fees are so much and everything. It was really heartbreaking, like to see all those things going. But what really happens? But I do know that there might be a disconnect for us to say that how are we going to do this? But there are people on ground that are currently doing this, which are the community-based organization. So I think my work is just to see as much as possible how to get creatively involved with them, so that I'm getting some of those really nice data from them, and hopefully we can begin to influence some of the policies that affect them directly. What's the second one?
I'm gonna wait. I'll let someone else go. I'll come back to it.
Thank you.
Yes, so I think that you really are tackling an important problem, obviously. Thank you so much for your presentation. I'm wondering if you've looked at anything at all with infant outcomes of these different moms and the different data that you're looking at, the different drivers of that. And if that's on your agenda to do, and if so, what would you look at?
So, like I said, so the Philadelphia PRAMS data set, even though it's similar in some way to the national PRAMS data set, does not, so, the only questions they have on infants is how long the hospitalization. And I think they also, no, they didn't even collect data on stillbirth or anything, so the only one they had was preterm births, like where's the babies? So it was quite difficult to dive into that. And they explained to me because the city also has another initiative where they get the people they call lived experience experts on stillbirth. And it's a very sensitive program because they'll be asking questions about the experiences of women who had stillbirth. So I am not involved directly in that study right now, but I'm like one with the Department of Health because I'm very interested to actually see how this play out for Black immigrants. But I will tell you, there's a data suppression issue for looking at ethically looking at how to protect the women as well, because some of the people that work directly with them are mandatory reporters. So apart from the fear of coming out if you're undocumented and you have this experience, the population I'm working with, I think right now is still very much opening up to the concept of research in this area. And again, culturally, looking at some of the key variables that are very important to infant health. If they're not culturally discussed, and for instance, it could be a trigger if you have a woman, do you have a child, stillbirth or something. So it's a burden thing coming out and I'm using Philadelphia as an example. Using the PRAMS data set, I am not able to use the entire PRAMS for the nation because I'm not able to disaggregate for the Black immigrant women. So this is me saying everybody should keep sending me good luck so that this gets funded. I'll begin to build these data sets over and over, and then maybe we can begin to make larger advocacy for actually collecting this at national level. That would be very important.
Just on this point, great talk. Thank you so much. One of the themes in your presentation was the need for better data, the need for disaggregated data. But this point that you bring up is the risks for your communities at engaging with research, providing data. So, I mean, what's the role of you as investigator or us as public health scientists to balance this in a way, getting better data, but also making sure that that doesn't injure or put these groups at harm?
That's a very beautiful question. Thank you. Community advisory boards, one word. So 3 words. One, so we were having this conversation today about cultural immunity, and that really gets me a lot of time. So like I was saying earlier, community-based organizations already do some of this work. They just don't have the infrastructure and the funding to like do it on the scale that we want to do them as researchers. I think that partnering with them, because they are protecting these people already, and they are doing a fantastic job in doing what they are doing. I think one of the most difficult things that I've had to do in building my network of community-based organizations in Drexel in Philadelphia area is having the community-based organizations actually trust the institution. And this is not about they will say, this is not about your person, it's about the institution. We have worked with Penn, we have worked with Drexel, we don't know how, it looks like I'm careful. It looks like people, the community-based organization feel like, okay, you guys are very smart and everything, but that might be a disadvantage to us right here. Now, that is where community-based advisory boards come from. This is bringing together several people, community navigators and everything together. And this has worked so well for some of the mental health programs that I've been seen some of my colleagues do, and I hear from that because I'm trying to transfer some of those infrastructure into what I am doing. So they bring the community leaders together. They were the ones who brought the 300 men to the mayor's office. So the community leaders know the people. The people trust the community leaders. They don't trust potentially also feel they will trust me at some point as researchers. So the community advisory board, if you sit down with them, will tell you this is not going to work, but this will work because they would make it work. So I think that is where and in that sense, it's like the chicken and the egg. That does not get you published very fast.
Yes.
Because you're like, give me something. I need to publish a little bit of data here. But that would establish us in the community and then eventually get us published often.
Great, thank you.
So I have one from a Zoom attendee, and this will probably be our last question. So, kind of continuation of your previous comments, but given the complexity of disaggregating data with large data sets, are you also considering or working with individuals that address postpartum and reproductive health continuity as well?
The last one?
Are you considering or working with individuals that address postpartum and reproductive health continuity as well?
Okay, so so one of the things and why I'm moving my work from just calling it maternal and child into perinatal health is because I'm just using pregnancy as a window into that maternal care continuum, pre, post, all of those things. So I do think that one of the things that I'm looking at right now, so let me say it this way. If it gets me the population I'm looking for right now, I will, and it will serve the community. If that's some of the priority, I think that it's a huge potential collaboration in that sense. Because what we want to do is to ensure that we are pushing as much out in data concerning this so that we can begin to gain some funding and traction and begin to get more data in to do more things. It's like a give and take kind of thing. So yeah, I think that's a good collaboration suggestion. Is the person there? I would like to talk to them.
Thank you so much. Very